Thank you so much. And sorry, I'm not there in person. I just got COVID, so unfortunately, I cannot join you, but I'm hoping next time I'll be there in person. And thank you for this wonderful introduction. These are my conflicts of interest. So I'll just take you through why it matters to think of multiple myeloma and its precursor conditions, and how can we think of interception in this disease. As you know, multiple myeloma is a plasma cell disorder, and it happens in about 35,000 cases per year. However, there is a well-known precursor condition to multiple myeloma, which is monoclonal gammopathy of undetermined significance, or MGUS, and the stage just before myeloma, something else called smoldering multiple myeloma. And in fact, both of those were described by Dr. Bob Kyle at Mayo Clinic, and I trained at Mayo Clinic, and Bob is now almost 97 years old. And when he described those 50 years ago, he really had the intention to try and understand what causes progression to myeloma in those pre-malignant conditions and how can we prevent it. You can see on your slide here that MGUS is in yellow, and it has a very slow rate of progression of 1% per year, which is very similar to many precancerous conditions in solid tumors. However, smoldering myeloma, as the name indicates, it's almost on fire. And you can see that now the chance of progression to myeloma is so much higher, 10% per year. And in fact, we have a condition called high-risk smoldering myeloma, which is even higher than the regular one, and those patients have a 50% chance of progression in 2 years. Now, in the old days, we used to say, well, let's watch and wait. There is nothing we can do about those patients. And once they have symptoms, once they have end organ damage, meaning fractures in their bones, anemia, kidney failure, then I will consider treatment. Until 10 years ago, when the Spanish, led by Mariví Matius, said, well, why don't we compare watch and wait, observation, to giving the patients 2 drugs that work very well in multiple myeloma called lenalidomide and dexamethasone. And indeed, we were shocked to see that there was a huge difference in progression-free survival and overall survival in those patients. And that changed completely the way we think. We suddenly said, well, there is an option now to treat early. However, that is not the standard of care, and we're still debating whether we should treat patients early or not, because we cannot identify in a very good way who is truly at risk of progression and who is not. Now, I think of multiple myeloma, and I worked for at least 19 years now in the myeloma field, and I've seen patients with multiple myeloma, and they come to us when they are symptomatic. They come to us in oncology when they already had the anemia or the fractures or bone pain. Their local doctor, diagnosed them with multiple myeloma because they ran the blood work, and indeed they found them. But if we want to change the history of cancer, if we want to really be thinking of what else can we do instead of being reactive, being proactive, we want to diagnose those patients early. And I think of breast cancer. When we see everyone for breast cancer, we usually say, let's screen it early because cancer screening saves lives, and we do mammographies. And I would tell you that the blood test for myeloma, meaning serum protein electrophoresis, is much easier to do than doing mammography or colonoscopy. And even when we diagnose patients with MGUS or smoldering myeloma, which is basically like a stage 1 or a stage 2 breast cancer, we don't tell them, let's treat you early to prevent metastasis. We tell them, watch and wait until you have fractures in your bones, until you have kidney failure, and then I treat you. And that would be a malpractice if I was treating breast cancer. That would be like saying someone, why don't you wait until you have metastasis? So for us to change the way we think of myeloma, we need to think of early detection. Can we diagnose them early before they have symptoms and be proactive? But also, can we identify who's truly at risk of progression and developing end organ damage and preventing it with interception before it happens? And this is basically the basis of what we do in our clinic as well as in the lab. We think of screening early, risk stratification, diagnosing patients at the right time, and knowing what is the biomarker that will indicate who will progress and who will not, but also developing interception, because without that, then we're just making them watch and worry and not do anything else. So we really need to identify potential benefits from early diagnosis. So I'll take you through those 3 areas. Early detection. We started about 6 years ago a study called the PROMISE study, and here we're starting to say, can we diagnose patients early? Now, we are not doing a regular screening study. We're screening people at risk, meaning people who are either of African descent or African Americans, or people who have a family history of myeloma or other blood cancers, because they have a 2 to 3 times higher chance of developing MGUS or myeloma compared to the general population. And we received the Stand Up to Cancer Dream Team application or grant with $10 million to really do this nationwide. And indeed, we did it not only at certain centers, but we said, let's open it nationwide by a QR code and have anyone who's interested to sign up and come and send us their samples, and we will screen for it. And the idea is that we screen 30,000 individuals so that we can have about 3,000 positive cases. And those cases, we will follow them until progression so that we can understand genomic changes, immune changes, biomarkers for risk of development, but also treatment that can make a difference for those patients. Now, since we started, we have almost 13,000 cases. We also opened it in the South Africa, where we have over 2,000 cases that came to us even during COVID. We also collected information from Mass General Brigham. This is a large prospective study that's here in the MGH and the Brigham centers, where we collect samples from our patients. And we started also working with PLCO and NHANES and other studies. And we're hoping to actually open it up in the UK Biobank as a way of retrospectively looking at the samples rather than prospectively looking at new samples. Now, what have we learned? We published this a couple of years ago with the first 7,000 cases, and we are doing it by mass spectrometry rather than by doing it the routine way of serum protein electrophoresis. So it's a much more sensitive way to detect very early clones of monoclonal gammopathy. And the first thing we found is a lot of people who are at risk indeed have a monoclonal gammopathy. Indeed, if you look at it, and I usually like to call this a Christmas tree, you will find that the level where we detect M spikes or serum protein electrophoresis is the dark blue. The level that we detect immunofixations is the light blue. And everything else that's below that, which is gray, usually negative if I use a clinical test, is now light blue in a mass spectrometry test. So we are sensitive to detect SPEPs, immunofixation, and something below the level of detection clinically. And this is what we call now monoclonal gammopathy of indeterminate potential, similar to CHIP or clonal hematopoiesis of indeterminate potential, because we did not want to confuse it with the traditional name of MGUS that Dr. Kyle has described. And I'm showing you here one of those mass spectrometry that's positive. Now, the definition of MGIP and MGUS, as we look at it in the general population or in the population at risk, you'll see that it increases with age exactly as it does with MGUS. And you see now that we finally have its chance of understanding how often do we see this. The prevalence of these in high-risk population is actually 13%. And that's because the general population would be around 3% if you use the traditional SPEP, which is what Dr. Kyle has shown. If you use a more sensitive test and in a population that's at risk, which is 3 times higher, you'll find out to be 13%. So that tells you that we have 13% of people who are potentially positive and potentially may develop myeloma in their lifetime, and we're not looking for them at age 40. Now, the other thing we did is we wanted to understand whether this MGIP, because most of them were IgM, will go on to develop myeloma or lymphoma or other things. And here you can see that we took samples from some of the MGIP patients, selected CD19 and CD138, and indeed we found by whole genome sequencing, by single cell RNA sequencing, that those samples are clonal, they're indeed malignant cells, and indeed there is a specific or a unique BCR in those patients, B-cell receptor, and we can track that until progression. So we're starting to indicate indeed that those MGIP clones are real and they can progress to myeloma or lymphoma. Now the next question would be, if I identified already someone who has MGUS or smoldering myeloma, what do I do? What do I tell this patient? You are going to progress in 2 years, in 5 years, in 10 years, in 15 years. We need good biomarkers that can help us understand who is at risk of progression. Now, clinically, what we use right now is tumor markers, meaning how much tumor burden you have. The higher the tumor burden, the higher the chance, of course, that you will progress. And we use something called the 22-20 model, meaning 20% cancer cells in your bone marrow, 2 grams protein in your blood, which is the M spike, and 20 light chain ratio, which is how much light chains you have. Again, these are based on your amount of disease burden, but not based on the biology. How fast are those cells growing? How bad is the underlying genomic abnormality in those patients? How bad is the immune system? All of those factors could be critical in being more precise in our risk prediction of progression in those patients. The other thing we do is we wait for bone marrow biopsies to be done. Now, if anyone has seen what a bone marrow biopsy looks like, you know that it's painful, it's inconvenient, and our patients don't want to do it, especially asymptomatic patients. So we said, well, why don't we use circulating tumor cells, CTCs, because when they go up in the blood of a patient, they are already prognostic that this patient will progress in the future. So with that in mind, we started to say, what is the genomic evolution from early precursor conditions of MGUS and smoldering myeloma to overt myeloma? We know very well what myeloma looks like. In fact, many of the studies with thousands of genomes have already told us how many genomic aberrations we have in multiple myeloma, but none of them truly had gone back to the early precursor condition to tell us what are the early events that occur and how does progression happen in those patients. So the first thing that we did recently, and this is submitted for publication, is we said, let's sequence 218 new whole genome sequencing MGUS and smoldering cases, and also put the 1,000 genomes that have been done by Compass, put them together and try to understand what is a myeloma-like genome in those early precursor conditions. Now, we've previously had done 250 whole exome sequencing and targeted sequencing, but now we're going to a genome level. And because some of those samples are truly at the very low level of cells, very small number of circulating tumor cells or very small number of cells in the bone marrow, we're talking about 5% of the cells, we had to do flow sorting. And then because we have a very small amount of DNA, we had to do a low input DNA sequencing to identify by whole genome sequencing those samples. And now we're down to actually looking at single cells for whole genome sequencing. And this work was done by Jean-Baptiste Alberge, and you will see that as we harmonize this data, we started to ask a simple question. Can I identify genomic aberrations that tell me this patient is more likely to be like myeloma or more likely to be like MGUS, more benign or more malignant-like? And if I add all of the genomic aberrations, can I make them into a simple score? 1 score low, 2 scores intermediate, and high score is high. And indeed, when you put the genomic aberrations in that scoring, you'll find that they correlate with the clinical markers of 20/20 high-risk smoldering myeloma versus low-risk smoldering myeloma. And indeed, not only it does that, but it can validate who will progress and who will not by Kaplan-Meier, and it can be used in an external validation cohort with the whole exome sequencing data that we had. And when you look at serial samples of some of those patients, and you can look at the phylogenetic tree, as you can see here, we find actually very interesting cases where you may have the early event was a p53 mutation, and then hyperdiploidy occurs, which is not what we usually think of. We usually think of hyperdiploidy as an early oncogenic event, and then p53 happening later on in those patients. And you can see indeed which clones are progressing and growing further as you go on with timing between the samples. We also found that the best thing to find is 2 years at least between samples, because that's when we see changes in the clones, and below that we may not be able to identify certain changes. That helps us clinically because now I can tell my patients we will do genomic sequencing every 2 years rather than every 6 months or every year. Now, the next thing we said is, can we identify the age of the tumor? And this was work done again with Gary Getz at the Broad Institute and Tim Cooper, where we asked the question, can we identify basically the mutational signature or the clock-like mutational signature of those, and go back and ask the question, when did that tumor start? And you'll see that when we have patients with multiple myeloma or high-risk smoldering myeloma, the tumor age is about 30 years, meaning that it's been in the body of that patient for at least 30 years. And when it's MGUS, it may be more like a 15-year-old or non-progressor. So it's a younger age of a tumor. That tells us how long the cancer has been there in the body of those patients, probably when they were age 30 or 40. By the time they get age 60 or 65, they get myeloma. But also it can be used as a marker of telling us how mature that genome is and how mature those cells are going towards myeloma versus early in the event of MGUS. The next thing we said is, well, can we look at the potential origin of those cells, and did they come from a plasma cell or not? And you can see here by looking at the potential methylation signatures of those cells, we were able to identify that those are germinal center or post-germinal center B cells that did the origin of those myeloma cells and progression into overt myeloma. Finally, and now we are in the Olympics, so we're looking at all of this competition. We did something called the league model competition. We're trying to see which events are early, and they happen in the MGUS stage, and which events will happen later on, more myeloma. So if I see a MYC or a deletion 12q or something else that will be more myeloma-like, I know that this is likely going to be myeloma rather than being only MGUS. And putting all of those together gives us this model where I call it more like the ladder and shoot game that we used to play when we were all young. You go in as an MGUS cell, and it may actually go on to stay as an MGUS cell forever, or it may just stay as a smoldering myeloma within that box of the game of malignant transformation and may never go on to myeloma. But if it starts going up the ladder and acquiring more and more mutations and alterations and tumor age and myeloma score, then it can go out to the other end of the game, which is the symptomatic myeloma. And by thinking of it like a ladder model, now you can ask the question of, if I have certain hits, 5 hits or 3 hits, or if I have a high tumor score or myeloma score, I know that this patient is likely going to get symptomatic myeloma soon. Now, you'll see that many of my postdocs in the lab are Swifties or Taylor Swift fans, so they decided to look at circulating tumor cell single-cell sequencing, and they called it the SWIFT-seq. So what is this SWIFT-seq? Basically, we said, let's do, instead of only whole genome sequencing, let's do single-cell RNA sequencing and B-cell receptor to identify the early changes that occur in the blood, not in the bone marrow, but also at a single cell level. And here what we did with 190 samples, bone marrow, peripheral blood on the same patients, healthy MGUS, smoldering myeloma, and myeloma, we started now to have over 1 million cells asking the question, what is different between a bone marrow and a peripheral blood malignant plasma cell? What is different between a normal plasma cell and a malignant plasma cell? And how can we identify those alterations that lead to progression? And the first thing we did, because we have the BCR of those patients, the VZJ sequences, we can tell what's malignant and what's normal within the same patient, intra-patient heterogeneity. And here you can see that even with very small numbers of circulating tumor cells, we can identify almost all of the patients having malignant plasma cells circulating in the blood, and it correlates with disease progression from MGUS to smoldering to myeloma, and also correlates with certain high-risk cytogenetics in those patients. Now, at the RNA level, you can see that cyclin D1 or cyclin D2 or MAF and other translocations could potentially be related to the underlying cytogenetic abnormalities of those patients. So you can classify correctly those patients as 1114 or 414 and so on at the RNA level in the peripheral blood and in the bone marrow. And you can see here that they're correlating very well with each other. Next, we asked the question, well, can I identify the cytogenetic abnormalities of those patients in the peripheral blood and with only 10 cells? And this is that confusion matrix that shows you head-to-head comparison with whole genome sequencing or FISH from the bone marrow compared to the peripheral blood single-cell RNA sequencing. We were able to identify them all. In fact, one case had 2 clones that only one was hyperdeployed in the bone marrow, but A1416 was in the blood, indicating that indeed those patients, you can identify them potentially with 10 cells as having cytogenetic abnormalities and avoiding a bone marrow biopsy and avoiding FISH with all of its problems. Next, we asked the question of transcriptional regulation and what is the proliferation signature, and can I look at the cell cycle of those patients' samples in the peripheral blood to indicate whether these are rapidly progressing, rapidly cycling and proliferating, and indeed giving us this biological signature of progression or not. And not only we can do that in all of the clones of the peripheral blood, you can actually look at the phylogenetic tree of certain subclones and how they look in the bone marrow versus peripheral blood. And that's critical. As you can see here, we have some subclones, like in the green one, that are more common in the peripheral blood versus ones that are only in the bone marrow or more abundant in the bone marrow compared to the blood. So finally, that puts it all together to tell you that potentially using circulating tumor cell single-cell sequencing may actually replace for us FISH and bone marrow biopsies, which are painful and not easy to diagnose. It can tell us if they have a proliferation index or a cell cycling index. It can tell us the gene expression profile and transcriptional regulation, which is something we don't even do routinely, or sometimes we do it with gene expression profiling, and it can give you the number of circulating tumor cells. All of those 4 in 1, a potentially easy blood sample to do. Now, the next part I'll take you through is the immune system. We really think of myeloma progression as an interaction between the tumor clone and the ecosystem that it lives in, and especially the immune microenvironment. And here, this is a paper that we published several years ago looking at immune single-cell sequencing, again, from healthy, MGUS, smoldering, and myeloma. And what surprised us is that even as early as MGUS, you have early compositional changes that occur exactly as it is in multiple myeloma. And we were surprised to think that even with MGUS, which you consider a benign disease, they look exactly like myeloma. Now, further changes can occur, transcriptional changes, and then further dysfunction of the immune system occurs as they go on to multiple myeloma. Now, with that in mind, we've now expanded this work, and now we have over 600 samples that we've sequenced, both immune single-cell sequencing with T-cell receptor in the bone marrow and in the peripheral blood. And this is work by Romanos Pistofidis, where you can see that when we look at just the aging signatures of the immune system, we find that indeed it correlates with age. But when you look at the, what happens with patients with MGUS or smoldering myeloma or myeloma, you find that this is an accelerated aging, basically as if you took them back or later, becoming older by almost 10 years. And that's significant because it tells you that that immune system, even correcting it for age, indicates that it is already exhausted or it is already affected by potentially the tumor clone and leading to further progression in those patients. Now, looking at the T-cell receptors in those patients, what we found that's interesting is, again, compared to healthy MGUS, smoldering myeloma, and myeloma, you have a significant change in the T-cell repertoire where it is significantly decreased, and you have certain subclones that are expanding in size. And we're now asking the question whether those expanded clones are tumor-specific or not and reacting to the tumor system or not. So now that we have that many samples, you can start asking very granular questions of which cells are upregulated between healthy and MGUS or MGUS and smoldering myeloma, and which ones are downregulated. And you can see the list. The typical ones for Tregs, granzyme B, CD8 TEMs, and so on are upregulated as you go on to progression, as well as downregulation of CD14 monocytes. And that starts to open the door of which ones came first, of course, and then whether we can regulate that for harnessing the immune system to prevent progression. Finally, and knowing that I have COVID, we asked the question, what happens when patients get COVID? And isn't that a perfect example of an internal change in your system or an internal challenge of your immune system? It was a perfect opportunity for us when COVID happened a few years ago to take samples that we've had pre-COVID vaccination and infections, and then samples post their first vaccination and their second vaccination, and ask the question, now that I challenge my immune system with a vaccine, what happens to that immune system in an MGUS patient or a smoldering myeloma patient or a myeloma patient? And that's critical because as we develop vaccines for therapy of our patients, we want to know if they will actually be able to respond. Even at MGUS stage, can they respond or not? And here you can see that, yes, they respond well, but they have a waning of their immune system very fast. And that happens even at smoldering myeloma and myeloma. And potentially there is an impaired T-cell response and impaired vaccination immunogenicity in those samples compared to a healthy population. That's critical for us to understand, especially now as we think of cancer vaccines to be developed in our patients. So I'll take you through the next step of, now that I've talked about early detection, risk stratification, immune dysregulation, can we fix this? Can we harness the immune system to potentially eradicate the disease or at least delay progression in those patients? Because even if we prevent end organ damage, that may actually be a good thing to do and just push it back for 10 years. But potentially, can we cure myeloma by early interception? And because we think it's so critical to use the immune system for our benefit, and because we have now, for the first time in myeloma, two basic methods of immunotherapy, either cellular therapy like CAR-T or bispecific antibodies that work so well in relapsed refractory myeloma. But we said, well, what if we use them earlier in smoldering myeloma, where your immune system is much better? It's still bad, but not as bad as myeloma, when you have less tumor burden and less genomically complex system, and that's probably the best time you can use your immune system. So to answer that, 2 years ago, we went to the FDA and asked if we can use teclistamab, which is a bispecific antibody, comparing it to lenalidomide and dexamethasone, the first option of therapy that I talked to you about in my first slide. And indeed, what we found is almost all of those patients had an impressive response. I'm showing you here the early data from 12 patients because this is what we presented in ASH, but this is ongoing where they had less grade 3 and 4 toxicities. So indeed, when you use those bispecifics early, they do not have the same cytokine release syndrome, they do not have the same infections, but more critically, every single patient had 100% MRD negative disease, 10 to the 6, meaning the deepest response you can get in your patients. And that was surprising for us because it was truly unprecedented to see such a high response rate and proves the hypothesis that indeed your immune system can work much better if you use it early on. And this is just showing you one of my patients, patient number 2 on the study. You can see his light chains were going up, almost myeloma, and he went significantly down back to completely normal within the first cycle and has been in an MRD negative disease since then. And you can see him here bungee jumping in New Zealand, enjoying a great quality of life. So I hope I took you through the last 30 minutes or so through what we can think of for one cancer, but we can apply this to many other cancers of early detection, screening early, and what are the options to do for those patients. Then risk stratification, because not every MGUS is the same and not every MGUS will go on to develop myeloma. How can we identify better genomic and immune markers that can predict progression? And can we use those in the peripheral blood because it's easier to track those patients? And then finally, how can we intercept the disease? And there is so much for the future of interception. We're just starting with immunotherapy. Can we do trispecific? Can we do cancer vaccines? Can we do targets that are not on the normal plasma cells, but on malignant plasma cells? And can we expand that to really eradicate the disease before it even causes symptoms in our patients? So with that, I'll stop and thank, of course, wonderful lab and clinical teams that I have at Dana-Farber and our collaborators. And of course, Gary Getz at the Broad Institute. We do all the work with him. And of course, our funders, MMRF, NIH, Stand Up to Cancer, LLS, and above all, our patients. Thank you.
Thank you so much. That was a really amazing talk. I'm sure that we all have a lot of questions, but I would love to ask the first one regarding, so I've seen your FISH plots where you identify a lot of the primary cytogenetic abnormalities, but I'm always surprised that 13q or monosomy 13 or 13q deletion would be considered a primary event. I think that since a lot of us are focusing on FISH and applying risk stratification using the FISH data, we really struggle with what to make of chromosome 13 abnormalities. Do you believe it to be a sentinel primary event? And why is it that the data are kind of difficult to interpret or sometimes conflicting regarding the risk stratification for chromosome 13?
Yeah, great question. So it may not be one of the early oncogenic events. It happens later, but it's such a common event in myeloma. I mean, almost 50% of the patients may have 13q deletion. In the old days, we used to think it is a bad prognostic feature. It increases proliferation. And in myeloma, it is no longer prognostically bad because we have drugs that work very well and overcome the challenge of proliferation. In smoldering myeloma, it is still prognostically relevant because of that increased proliferation and potentially then increasing the risk of progression from MGUS or smoldering myeloma to overt myeloma. So that's the difference between a smoldering myeloma, considering it high risk, but it's not high risk in overt myeloma. I don't know if that answers your question. And then the best thing about 13q is you can really see it in the RNA sequencing. So it's so easy for us to detect it, yes or no, in those patient populations.
Thank you. Do other people have questions?
It's an absolutely fantastic talk. I enjoyed your presentation so much, and that's amazing data. Thank you so much. Following up on Linda's question, so we knowing from the cytogenetics perspective, like detection of monosomy 13 on metaphases was considered aggressive and poor risk marker. If it's just detecting by FISH, it's not associated with poor prognosis. So when you are using the novel, of course, NGS and RNA sequencing-based methods, that, or especially in a single cell level, I feel like, how do you kind of correlate with the prognosis in that regard? That's the first question. I'll let you answer first, then before I ask my second.
Yeah, and the reason why we did not consider it by FISH versus cytogenetics is the proliferation, right? If they're growing and proliferating, then you'll find them by cytogenetic. If they're not, then you find them by FISH, but not by cytogenetic. So it was a reflection more of the proliferation rather than yes or no 13q. And now we can do much more, right? You can look at the single cell level cycling, proliferation. You can look at so many other things. So I don't think we depend only on that anymore. And again, in overt myeloma, it may not be as critical as it is in smoldering myeloma. And maybe hopefully with all the treatments we're doing, it may not be relevant anymore in smoldering myeloma.
Yeah. Okay, thank you. So regarding my second question is about this progression, from MGUS to smoldering to full-blown myeloma. So you have, I may got it incorrectly. So earlier when you say which were early event versus later event, seem to be slightly different from the different progression stage, or are they exactly the same actually? So in other words, what we consider today as high-risk markers in multiple myeloma, are they also implying, if they were seen in MGUS and smoldering myeloma patients, are they also implying that they have high risk for progression?
Yeah, it's a great question. And the best example would have been 13q, not high risk in myeloma, but high risk in smoldering purely because of the proliferation. MYC alterations, and although they are very important in myeloma, we don't usually routinely put them. If you look at the IMS data, it doesn't even have MYC. But MYC is such an important marker for smoldering myeloma. Sometimes we call it almost like the genomic definition of you're going to be overt myeloma. MAP kinase mutations are prognostic in smoldering myeloma. They're not in overt myeloma. I think the difference is in smoldering myeloma, you're looking at prognosis of progression to overt disease independent of any drug therapy. You're looking at the natural progression. So it really tells you yes or no, there is proliferation. In overt newly diagnosed myeloma or relapsed myeloma, the prognosis is also depending on the therapy. Will the therapy overcome the resistance? So therefore, the drug resistance mechanisms, P53, 17P, 414, and so on, may be more relevant, 1Q amplification. So yes, they are the same because bad actors are bad actors wherever you go, but maybe there are more bad actors or different actors in an earlier disease setting than the later one when you have drug therapy.
That makes sense. Thank you.
Thank you, Irene. Wonderful talk. My question goes back to your analogy to the game. As you feed in and you start gaining abnormalities and you're pushed out then into multiple myeloma. You mentioned you have a score now. So are you intending to put that into a clinical trial in a prospective setting, and also to study the impact then of treatment of those patients who come out on the top with the potential, and how that may, if you can give us some insight perhaps about how that may affect us in clinical laboratories? Are we going to have to start for those patients where we see high-risk patients for this, are we going to have to start implementing enrichment for circulating tumor cells and then perform this genomic score? How do you see that playing out?
Yeah, I'd love to bring that to the clinic, right? That's the, and people say, oh, you cannot do whole genome sequencing, you cannot do it in the clinic, but it's very easy. Whole genome sequencing these days will get to $100 per sample, right? It may actually be cheaper than FISH in the near future. And it may not be that hard for us to implement a scoring system like this. That's why we wanted it to be a very simple score based on multiple well-known identified mutations, copy number alterations that are more myeloma heavy versus MGUS heavy, basically. And if you identify that, that can give you a tool in your hand beyond clinical markers to tell you, indeed, this patient is likely to progress. So yes, and in fact, we just started an FNIH grant to try and make the myeloma risk assessment, not just a clinical assessment, but genomic and immune and CTC number. And you add all of those together and you can give to a patient their own personal risk stratification. You can be more precise in telling them, you are going to progress or not with a more precision than 30% or 50% risk of progression. You can say, I really know it's a year and a half, or it's 2 years, or here's your score genomically, here's your score by CTCs. And I don't think that that's, very far from now. We can actually do that if we bring it correctly and work together in implementing it in multiple factors or studies. Now, how do you use that in the clinic? You could potentially say people who have a genomically high risk will go on a clinical trial. Of course, you can compare it to observation or other therapies so that indeed you show that that matters in those patients. And then the next question is, which treatment works? Maybe immunotherapy works for everyone, but maybe their VRD or their QRD may not work in those high-risk genomics. So now you're adding the same layers of complexity that you have in myeloma of which option of therapy would work for which patient.
Thank you.
Hi, just wondering would you know if there's any studies that are looking at like sequencing plasma cells to maybe ascertain a little bit better where the IgH breaks are happening in that locus and whether that changes prognosis at all?
I don't know. You mean like clinically, or what do you mean? Because with whole genome sequencing, we can actually identify the IgH locus. So I'm not sure if that, you mean clinical whole genome sequencing, or what do you mean by that?
Or on the research side, if there's sort of enrichment happening and then you would sequence. I was only asking because I thought I heard about some studies that were coming out of Europe that were looking to define where the break points are in that locus, and there was some argument for things becoming less like poor prognostic IgH MAF rearrangements, but depending on where the locus was, it was becoming more of an uncertain finding. So I don't know if that has any merit or.
Yeah, so we isolate circulating tumor cells or bone marrow plasma cells by doing enrichment with CD138 selection by bead selection, and then we do flow sorting. So our tumors are very pure, at least in our studies. With whole genome sequencing, you can identify the locus of IgH translocation. I think the problem was FISH or exome sequencing that does not identify the IgH, where you do have that problem. So I think with whole genome sequencing, you overcome that burden that you may not have had with the other studies.
Online question. The question is, how do you correlate your study findings with plasma cell leukemia?
Yeah, the other spectrum, right? I don't know. We work on the very early spectrum. The moment I see plasma cell leukemia, I'm like, well, but yeah, it's very important because if you look at circulating tumor cells, what makes them circulate? It's the underlying biology, and plasma cell leukemia is the extreme of that underlying biology. It's, genomic aberrations, likely a lot of the p53, lots of MYC, lots of alterations that increase proliferation and makes those cells less dependent on the adhesion to the microenvironment of the bone marrow, or less dependent on, being attached to the surrounding environment. But I have not done a lot of work in plasma cell leukemia. I wish I am doing it because it would probably make us understand more about that disease.
That's a great discussion. I have a question: is that for most of the institutes, the the cytogenetic and molecular standout test, and then after you send out, after a weekend, when they receive the specimen, all 138 is gone, and enrichment usually is failed. So we really don't have that much data about the cytogenetic change or molecular change of early myelomas in the community. So do you recommend any better study modality for this population, for those like low volume disease, instead of just a marrow fish?
Yeah, no, I agree with you. I think some of our studies, and we do bone marrows and send actually our fish to Mayo Clinic, and we have 30% of them come back fish failure because not enough plasma cells were enriched. I agree with you. We just started, and I had it on my conflict of interest slides. We just started a new company trying to ask that question. Can we do circulating tumor cells isolation, minimal number of cells, whole genome sequencing, truly to overcome the problem that we have with fish and bone marrow? So if things work out well, maybe that will be one of the answers that we can provide to our patients.
Thank you.
I have another question. one of the goals would be to transition away from FISH to do whole genome sequencing. But I realize that we face a lot of challenges with that, mainly because FISH we're comfortable with FISH and it's fairly quick. A rapid FISH test can be done, not for myeloma necessarily, but for other malignancies where we can have an answer within 2 hours. I do think that when we do whole genome sequencing, there are more complexities. It's not as readily reimbursable as FISH is, and I do agree with you that it is a cheaper test ultimately at the end of the day. The informatics is also more complex. I guess I struggle with, how do we actually convince the payers that this is a much better test to do whole genome sequencing? We can get a lot more information, and our prognostic models will be probably more robust. And even when we incorporate other things like the tumor microenvironment, everything will be hopefully better. But it's just a challenge with how do we go from FISH to actually implementing whole genome sequencing.
Yeah, I think that about that all the time as we started this company, because we do want to convince payers that it matters a lot for us for doing whole genome sequencing compared to FISH. But I think of it more as a physician who sees a patient. If I treat today a patient with a BCMA deletion or a GPRC5D mutation, I did not know that at all on FISH. And yet I treated them with a $500,000 drug or a $1 million drug, CAR T therapy, and they did not respond. The insurance company will not like that. The patient will not like that, and the physician will not like that. And it would have been a very simple, easy test to do by looking at whole genome sequencing. And I think as a physician, shame on us that we are in this day and age not doing that before we give our patients a CAR T or a bispecific. That should be the minimum we do for them so that we know, do you even have the surface antigen or not? And should you be responding to this therapy? So these are things that are not even on FISH, let alone that FISH, as we said, is not sensitive, not specific, in some cases misses a lot of the alterations, the MIG alterations, and we owe it to our patients to be more precise in what we're giving them for therapy. So it's not just prognostic, it matters a lot for when we're treating our patients to say, will this therapy matter or not? And I think insurance companies will be looking at that because they know that we treat myeloma patients forever, 15 years, 20 years, and we cycle through drugs without thinking which one actually works and which one doesn't. So there will be a point where they say, show us, just like any other cancer where they do FGFR3 mutations before they treat them, or they do ALK before they treat them, and so on. We need to be at the genomic era of many other cancers, and we are a little bit behind, a lot behind actually, compared to other cancers.
Yeah, I still feel like we have to have some way to really convince people. And I agree, we're spending so much money on CAR T-cell therapy and other therapies. The treatment costs are so expensive, but still during the diagnostic workup, there's just this lack of interest to spend so much money. It is truly an investment, I think.
Yeah, and hopefully as genome sequencing is cheaper and cheaper, as we said, it is probably already cheaper than FISH, but you do need the infrastructure, the bioinformatics. You need to know what you're doing, and it's getting better and better. People are getting good at doing that analysis. Just like FISH was 30 years ago, it was hard, not everyone knows it, and now everyone can do it. It requires a little bit of understanding how to do it correctly.
Also, what surprises me is I think that the chromosomal microarray is somewhat underappreciated in the myeloma community. This is one, of course, we cannot detect balance rearrangements, but we could at least identify chromothripsis and complex genomes. And again, it's under-ordered, I believe, in many institutions.
Yeah, we're very good at staying the old course, right? Not changing. So it requires a lot of work to make us change.
Audience.
Thank you. I have another question. There's a recent European study based on flow cytometry for MGUS, separates like MGUS-like or myeloma-like MGUS by immunophenotype. What's the molecular background of these two subtypes? Did you follow up that one?
Yeah, I think that's Bruno Paiva, the Spanish study, and it's basically flow cytometry, if I remember correctly, the one you're talking about, unless I'm mistaken. But I think it's based on number of circulating tumor cells, but also the phenotype of those circulating tumor cells. Do they have CD56 and other things? But I might be wrong, so I'll have to double check which paper you're talking about.
when you are referencing. Did you look at the molecular of these two different subtypes to see whether they have a molecular difference between these two?
Molecular difference between MGUS-like and myeloma-like?
Correct.
So genomic differences are what we described in those patients. When you mean molecular, what do you mean?
The FISH and actually the cytogenetic and NGS, did you compare these two groups to see what's the difference?
Yes, so that's how we defined the score. We actually found differences and we identified the score by using multiple different mutations or copy number alterations that we called, they are more like multiple myeloma and they're more genomically complex. Let's put those into a myeloma. We actually created the score based on the molecular differences between them.
Are there other questions in the audience? Well, if there is one coming.
Ask another question. So basically, it's technical. It's just regarding, you mentioned about the flow sorting those cells, enriched cells, and then before RNA sequencing. I was blown away by that, how beautiful the data was. So I was just thinking, we had tried flow sorting before. It was the plasma cells tend to be very kind of difficult to manage by flow sorting, and they somehow they look like fried afterwards. So that's how we decided to not do flow sorting, but turn to just enrichment by beads, like CD138 beads, in a magnetic beads method. So I just wonder, technically in your hands, how do you, like, for RNA sequencing, I would think the quality of the RNA is even more important from those cells that you flow sorted. How did it look in your hands? Is there any special tricks in terms of getting them to be intact and good?
Yeah, so one correction though, the flow sorting that we did was for the DNA sequencing, for the whole genome sequencing. So we do 138 selection, or we directly go for flow sorting, and then we get the pure cells and we do whole genome sequencing, bulk or single cell if we need to. For single cell RNA sequencing, because you already can tell, because you have the B cell receptor, right? You have the VDJ, you don't need them to be pure. You can just run a CD138 selected, bead selected sample, and you'll have normal plasma cells, malignant plasma cells. You may also have some other cells that came into the bead selection. It doesn't matter because you have the VDJ sequences. So now you can identify which ones are malignant or not. So if I put 10,000 cells and 4,000 of them are malignant, that's more than enough for me to call that clone is the malignant clone. And then I can look at subclones. So for single cell RNA sequencing, you don't need to be pure. And we don't need to do flow sorting before we do it because we don't need them actually pure. You want a lot of other cells with them. For whole genome sequencing, we want to be as pure as possible. You don't have to be that pure also. I mean, if you're doing 60x coverage, you can be 40% pure and you're fine.
Okay, and you also mentioned like you were doing CD19 combined with the CD138 for sorting? Or is it just 138?
No.
Just this.
No.
Okay. Thank you.
We can 19 negative.
There is a question in the online forum. So I guess as a background for this question, one advantage to FISH is that it has the potential to be more sensitive than whole genome sequencing, but FISH is not an MRD assay. But the question would be from this individual, for MRD, which assay would you recommend when we are already just switching to whole genome sequencing?
So for MRD, we're using adaptive, which is VDJ sequencing, basically, of only the B cell receptor, right? You're not really looking for whole genome sequencing. And we don't need whole genome sequencing when you're looking for minimal disease where there are no cells left. In fact, we may not have enough tumor plasma cells to do any whole genome sequencing. So it's really a detection or lack of detection of any clones, which is the VDJ sequencing of adaptive.
Are there other questions that people have? This would be the time to ask. It seems like there are probably no other questions, but Irene, we really thank you for taking the time, and I hope that you feel better soon after your COVID infection, and we're really grateful that you presented today, despite the fact that you have COVID.
Absolutely.
Thank
And
you.
thank you again.